Hi everyone. I think I know most people. If you don't know who I am, so Grace McComsey, I'm the PI of the CTSC of Northern Ohio. And it's my honor actually to present a speaker that we're really excited to hear from, Dr. Emily Pfaff. She's a research associate professor and informatics leader in the Department of Medicine at UNC Chapel Hill. She's co-director of the Informatics and Data Science Core at the North Carolina Translational and Clinical Science Institute, or CTSI, where she serves as a technical and governance leader for UNC's local clinical data warehouse. She also directs there a team of 30 informaticians, data scientists, and project managers who together support hundreds of data-driven research studies at UNC. Also beyond UNC. Her primary expertise and research interests are, as you can guess it, in electronic health record data, computable phenotyping, clinical data modeling, and clinical data analytics in support of translational research. So it's my pleasure, Emily. We're looking forward to your talk. Thank you for accepting the invitation.
Thank you so much for having me. I'm delighted to be here. And there were a lot of topics that in this space that I could have chosen to talk about, but I think something that's getting the most attention and that I think is well worth the discussion with other folks who are interested in this space is doing electronic health record research across sites. So not just limiting your analysis to the data available at Case Western, but actually collaborating with other sites and putting these data sets together in a way that they can be analyzed concurrently. And there's a lot of excitement in that area. There's also a lot of pitfalls, and hopefully we'll talk about both of those things. So I'm at UNC Chapel Hill, and so I spend a lot of time thinking about North Carolina. And so this is my denominator. Now note that the entire state isn't my denominator. You see that these counties where UNC has a presence is my denominator, because when I use UNC Chapel Hill data, it is not the population of North Carolina. It is the sort of catchment area of UNC hospitals. I am actually from Shaker Heights. So you can actually envision this being a map of Ohio and Cuyahoga County being sort of blasted over here, and that's your denominator. Now, UNC Health is huge. It is one of the largest health systems that I personally have worked with. We have about 7 million patients in our clinical data warehouse, and they span, as you can see here, across the state. So it's a pretty big denominator. But I think particularly when we're talking about particular use cases, which I'll talk about in more detail a little later in the talk, we want to think about how we can go from using this denominator to this denominator, where we are actually looking at the entire nation, and in some cases, the entire globe, but we'll focus on the US for today. As I think many of you may be aware, every healthcare system has their own electronic health record. And that wasn't really the case until 2015, 2016, which frankly wasn't that long ago, where there were plenty of institutions that didn't have electronic health records yet. But now in 2025, it's the norm. And so every healthcare system is doing this. But as you can see in this illustration, all of those EHRs are completely isolated from one another. They also are apples and oranges in that they are all EHR databases, and they all sort of have the sort of main things in common. They're all fruit, but there are enough idiosyncrasies at the different instantiations of EHRs across the country that they're really not entirely comparable. And that makes it very difficult to do multi-site research, because even small differences between apples and oranges make it so that we can't combine data sets easily. And if we can combine the data sets, but we don't know exactly what those little idiosyncrasies are, we're not going to combine them in scientifically rigorous ways. We're going to have missing pieces and things that don't quite line up. But what if we could query all of these at once? Certainly there are countries where this is possible, and I think that it is becoming more possible in the US although we do it differently than countries where they're actually harmonizing all of their EHR data at a national scale and don't necessarily have this silo problem. But I want to talk about some ways where we can query data all at once, but then talk about the things that you have to keep in mind when you're working at this national scale with all of this disparate data smushed together. So let me do a little bit of definition work first. When you're doing multi-site research with EHR data, there are really two approaches, and I'll just sort of oversimplify it by saying there are two approaches. There's more than that, but the two categories are federated work and centralized work. So in a federated system of electronic health record research, I, as a researcher, have a question, and I have a specific query that I want to run. So you can see in the illustration here, the specific question is, how is time on ventilator impacted by drug X? I, as the investigator, can write that query. I can write it in pseudocode by just describing it. I can actually write it in actual computer code. And instead of asking everybody I'm working with to send me their data, what I do instead is I send my code out to my partners. And the reason that this is a nice model is because, as I'm sure is just as much an issue at Case Western as it is at UNC and everywhere else, sharing data, particularly sensitive data with identifiers in it, all across the country is not impossible, but difficult. It's a high friction proposal. And so being able to say, no, I don't want all the row level data for the patients. I just want the answer to my question so that I can pool my results. That is generally a much lower lift and less controversial. So there are some distinct advantages to that federated model. But federation does have some disadvantages in that when you're working with federated data, you can't interrogate the data as deeply. You can't get in there and spelunk around in the database and do really in-depth fit for purpose analysis and quality analysis. You sort of have to, it's a very high trust situation where you have to be really trusting of your collaborators' data quality and data transformation practices, because all you're getting back are those results. So the other model here, centralized analytics, is the model where everybody is sharing their raw data with each other, their row level data with each other. And that way, I, as the investigator, I'm not sending my query out, I'm actually able to execute my query or research question directly in the data. And there are some methods that are easier in the centralized setup than a federated setup. So again, there are distinct advantages to that as well. We don't like to say that one is better than another. They're just used for different things. And today, I'm mostly going to be talking about centralized analytics, but I do encourage folks to take a really strong look at doing multi-site work on a federated network, such as PCORNet and the Odyssey network, because they really are great for a ton of research questions, and you'll get stuff done faster. So here are some use cases for real world data at scale. You'll see I have this acronym in the title here, and you may or may not have heard it before, but it is becoming more and more a term of art when talking about electronic health record data. And all real world data means is that it's data that wasn't collected specifically for the purpose of research, but we can use it for research. So in this case, EHR data, of course, is collected during the course of care, and it has enough information to be really useful for research, even though it's not that sort of clean, regimented, protocolized data collection that we see with a fit for or a purposeful research data collection exercise. So what can we do with real world data? There's lots of stuff, and we'll talk about some specific examples of these use cases as I continue to talk, but you can use real world data for disease surveillance and find pockets or hotspots of different diseases at either a county, state, national level, things like that. For rare disease research, as you can imagine, if you're only working with one site's data and the disease is truly rare, you may only have a handful or even no cases of a particular condition. But if you pool data with many collaborators, all of a sudden you have enough power to really be able to do some rare disease research. Machine learning and AI methods are data hungry. And the more data you can give them, often the better results you can get. And so pooling your data across a large number of sites can really have better results in those kinds of use cases. Same things with target trial emulations, which I'll talk about later, where we're actually trying to emulate a randomized control trial in data. similar thing where if we're going beyond a single site and bringing together maybe sites that are even very geographically dispersed or have very different populations in their catchment area, that's going to make the trial more robust as we're doing it. And then finally, sort of a catch-all category, which is there's a lot of research questions where you want to avoid the idiosyncrasies of a single institution. Because real-world data is captured very pragmatically, and because there are cultures at each healthcare institution as to how data are collected, those can actually confound your analyses, those idiosyncrasies. So when you pull data together, you can sort of lessen that effect a bit, and that can be really, really useful. Okay, so let's talk about the complexity of smushing together multi-site data. Let's go back to our apples and oranges, where these two patients both have asthma, but they go to different hospitals, and those hospitals, talking about local idiosyncrasies, have different cultures of data collection. Hospital A has their database behind their EHR where they have a patient ID, and they have a diagnosis code for asthma, and that's in the ICD-10 vocabulary. And we have a column that says that diagnosis code specifically appeared on the problem list as opposed to other sources of diagnosis data like billing. And we have a diagnosis date. Now at Hospital B, similar but not the same. We have a patient ID, has slightly different format. In this case, this particular hospital uses SNOMED as their diagnosis coding of record. And so even though this both equates to asthma, this code looks nothing like our J45 there. And so already we have a harmonization issue. And even things that are really simple, like saying where the diagnosis comes from, like the problem list, the Hospital B just notes that differently. There's still a flag that says it comes from the problem list, but it's not the same as Hospital A. And so the same query, the same code would not work without significant modification at both hospitals. And so you can see that even when we're using controlled vocabularies, even when we have pretty well-structured data, they're different enough to make it still difficult to work with. So this leads us to the rise of the Common Data Model, or CDM. And a Common Data Model is a structure for data that I and all of my favorite colleagues at other sites can agree upon for storing our EHR data. Now, the way we used to do this was we would just, let's say I was working in a consortium with Duke and Wake Forest and UNC, which is a common experience because we often work together in the state of North Carolina. You could absolutely imagine that Duke and Wake Forest and UNC could invent our own data model and say, all right, for this study, this is how we're going to store patient information. This is how we're going to store diagnosis information. But the problem with that is that you end up with a million different data models that a million different consortiums have come up with for specific use. And that's not interoperable. That's not going to solve the problem at a national scale. So the logos that you see on this slide are logos for either open source communities or consortia or even companies that have decided that they wanted to do this at a much bigger scale and define a data model that goes across sites, across states, and enables us to store data consistently in an interoperable manner. Now, this would be easier if there was just one of these models that everybody could agree on. Of course, that's not the case. That would be too simple. And so we do often have a case of data model mismatch, where maybe I am using the Odyssey data model, which is also known as OMOP. You might hear me say OMOP in this presentation. And another site is using the CoreNet data model, and we still don't really have an easy way of communicating with each other. So this is not a perfect system, but it does certainly simplify things when compared with me creating a brand new data model every time I want to do a new study. But in order to get data into those data models, we have to do a process called harmonization. And this is where we take the raw data that comes out of our EHRs at our individual sites, and we transform it to meet the specifications of those common data models. And this step is one of those things that it's not very fun to talk about because it's very in the weeds. It feels very much on the back end. And it can be very tedious. And this is something that I like doing. This is my research interest. And even I admit that the process of harmonizing data, there is this tedium aspect to it. But if you don't pay very careful attention to this step, then all that downstream analysis that you're really excited about doing is based on really poor quality data. And so as tedious as this can be, as sort of back office as this can seem, to me, this is the most important step of doing multi-site EHR research. Now, as I said, those common data models allow us to harmonize data in a standardized way. And moreover, some of you may be familiar with the various medical terminologies that are used in the electronic health record. I mentioned a couple of them a few slides ago. ICD-10 for diagnoses and procedures. SNOMED is also useful for actually multiple domains, but particularly diagnoses. RxNorm is really useful for coding drugs. And when data are labeled with those standard terminologies, there's a natural roadmap to harmonizing them because they already follow some standard. And I know that if I put my data in ICD-10, it's going to have the same meaning as my friend down the street who also uses ICD-10. But I think what goes underappreciated is the fact that in the EHR, there is a whole lot of data that has no standard whatsoever. And that means that humans, and maybe soon with AI help, but for right now, humans are doing all of those standardization steps manually. I'm going to give some examples that are particularly sticky, but the list here kind of shows you the important types of data that are simply not being mapped in a structured way. Flow sheet data, so anything that's captured in a flow sheet is often just completely Wild West in terms of how it's coded. All of the free text, clinical notes and reports and things like that, that's all just free and free of standardization. Visit data and even demographics. We can't agree on how to code race, ethnicity, and sex. Those things are left up to the institution and can be difficult to harmonize as well. So there be dragons in this area of mapping, and I'm going to show you a couple of those dragons now. So let's talk about visit data. If you recall when I talked about federation and I said I can send out a query that I have written to my friends at other sites, and those sites will run my query in their data. This example that you're seeing on this slide is that process. In this fictitious example, I've sent out a query looking for the number of visits at your hospital where a patient had COVID-19 and was on a ventilator. And site one returns a number to me, says, great, we have 43 qualifying inpatient visits for your question. Site two, which I know is a little smaller than site one, says they only have 27, and that makes sense to me because they are a smaller hospital, so that feels in the realm of possibility. And then site three says they have 806 visits. And I know that site three is not that much bigger than site one. And so to me, this doesn't mean that site three has sicker patients. It means there's a data issue. And when I actually have a chance to interrogate the data, what I see is that site three defines what a visit is very differently than what site one and site two define as a visit. This is a real scenario that happens all the time, even though the data on the slide is fictitious. But you can see here that at site three, instead of having a single inpatient visit that spans all of the days of a patient's time in the hospital, they actually make a series of inpatient visits to capture various parts of that. It may be, for example, that they create a brand new inpatient visit every time a patient is transferred to a new location in the hospital. That does happen. So all of a sudden, if we start counting visits over there, it just doesn't mean the same thing as site one and site two. And in fact, we put out a paper on this exact topic a few years ago because I was just fascinated with this idea that visits are so important for electronic health record analysis, particularly if you were running a question that is very hospitalization focused. So you really want to know, was this patient an inpatient or not? Or was this patient in the ED or not? For that information, you have to interrogate the visits. You can't ignore that. But this diagram is showing visit data, and it is real data, from 4 sites that we have anonymized with just numbers, so site 19, site 37, et cetera. And you can see how differently each of these sites structure their visit data. So my favorite one is this one on the right here, site 46, where this is for a single patient, by the way. So a single patient at a single hospitalization, in this case, it's a 20-day hospitalization. And you can see that big stack of green lines there. This is a hospital that makes multiple inpatient visits to cover different components of an inpatient visit. So I can't even count how many lines there are there, but rest assured it's a bunch. So you have that to contend with. But then additionally, all of these other stacks of little blue tick marks that are so small you can barely see that they're tick marks, those are unlabeled visit types, but they are separate visits that have occurred inside this inpatient visit. Now, I know that when this happens, sometimes it's because the patient is wheeled down to MRI, and MRI makes a separate little tiny visit inside the inpatient visit to reflect that the MRI happened. Now, clearly, this patient had a lot of those types of activities, and they're all stacked up on top of each other. So if I was trying to analyze this data, first of all, I could not have a consistent method to deal with this across sites because, as you can see, they're all so different. And I also would have to be very, very careful to make sure that I was capturing all of the bits and pieces of data that are attached to each one of these little tick marks, instead of assuming, as I would like to assume, that all of the data that I care about around that hospitalization is contained within one of these green lines here. So you can see how complicated and messy this truly is. And remember that visit data, unlike the diagnoses and procedures and medications, just doesn't have a nationally accepted vocabulary that helps us harmonize definitions across sites in an easy way. Second case study that I want to talk about is flowsheet data. Flowsheets can capture basically anything and everything. If you want to capture something that isn't currently being captured in your EHR, you can create a new flowsheet in order to capture that data. And in the last few years, one of the newer flow sheets that is coming out at many different institutions, no matter what EHR you have, is a flow sheet to capture individual responses to social determinants of health questions. So things like, do you have food insecurity? Do you have transportation insecurity, et cetera? Those questions are really interesting to researchers for all of the obvious reasons, but like the data that we've just been talking about, it doesn't have a nationalized vocabulary and can be very difficult to harmonize. So we wanted to do a study with these and realized that this was going to be a problem. And so we actually had to crowdsource the mappings that we wanted to use so that all of the sites that we wanted to work with would just sort of agree with each other that they would code these questions and answers the same way. So you can see here in blue, those are the internal UNC EPIC name for these particular questions and answers in our flow sheets that didn't always match the flow sheet EPIC name at even other EPIC sites. And we all got together and decided that we were going to map, this question to this link code and that answer to that link answer, so that finally, when we pulled the data, we were able to actually use it in a harmonized way. I bring up this case study, not to say that this is impossible work, but it was necessary work. Otherwise, we wouldn't have been able to do harmonized analysis, and it took a while. This was manual effort on the part of humans, and it was a critical step that we certainly could not have skipped in order to do the study. Now, when you have multiple sites that are submitting data, no matter what domain it is in, it is really important to be able to not only tell people how you want them to harmonize the data, as we've just talked about, but to also give them feedback, because not everybody does things correctly all of the time. You might be shocked to hear. There's human error, and there's also just structural data errors or funky things that need to be ironed out in order to do good science. And so I'm not talking much about the National Clinical Cohort Collaborative, or N3C, that I've worked on for many years with NCATS. N3C is currently on pause, but we've done a lot of work on N3C over the years, harmonizing EHR data submitted from over 90 sites across the country. So we've gotten to see firsthand exactly how messy this process of harmonization can be, particularly visits. So the reason I'm showing this example is that you can see here over in the A panel of this diagram that when sites started to submit their visit data, we wanted to try to figure out what a normal site looked like in terms of % of their visits that should be inpatient. And so you can see the shaded area down here is the average a percentage of inpatient visits at a hospital. And certainly they're not all the same, but they're all within a reasonable range of each other. And this site here, and this is a real data, this site here submitted data suggesting that 12% of their visits were inpatient. And it was such an outlier that it gave us pause. And then that spiked in a future payload. So this is over time, data that they've submitted over time to the consortium. We see that spiked to almost 16% inpatient visits, and that didn't seem right. Long story short, turns out that they had a mapping error. So they were labeling data as inpatient visits that actually were not inpatient visits. You could imagine that that probably caused some problems at their local site when they were provisioning that same data to local investigators, but it certainly caused problems for the consortium. We were able to see the problem because we did this cross-site benchmarking. And that's really the takeaway from this particular effort, is that if you're doing multi-site research, benchmarking everybody, benchmarking each individual participating site against the average of everybody else on a variety of metrics is really, really helpful, because you can see that once we caught the error, all of a sudden the site fixed it and they're back down in normal land down here. And then the same pattern you see over here is that some sites actually were submitting data with 0% inpatient visits, or a very low percentage of inpatient visit. They had the same problem in the opposite direction, where they weren't labeling visits as inpatient that actually were. And you can see that as we gave them feedback and as they kept resubmitting their data, all of the sites improved at least a good amount over time. Okay, so we have done all of the harmonization work. You now know everything there is to know about data harmonization, nothing else to say there. I now want to turn to what can happen after we've harmonized the data and we start working with it, and what to look out for there. So the first thing that's necessary to always keep in mind when you're working with EHR data, or really any real world data, is missingness. And missingness just looks different in the EHR than it does in a collected for research purpose data set, because it's very difficult to know why something is missing, and it's difficult to know how to interpret that missingness. In my example here, the question is, does this patient have COVID-19? Well, in 2020, in August, they had a COVID test and it was negative, okay? And then the next time they show up in the data is in 2022, so 2 years later, and they have a visit for fatigue and dyspnea. I got no COVID data whatsoever, so no positive COVID data, rather. So in my definition that I'm using in the EHR, I might consider this a non-COVID patient. However, what we don't see is the positive home test that happened in March of 2022. There would be no reason for that to be in the EHR for most reasons. And so I'm just not seeing it. And that means that if I try to use this patient in my analyses, I am at risk of labeling them as, for example, a negative control instead of what they actually are, which is somebody who had COVID, but we just have no record of it. There's a sort of a more common version of this problem that I see quite a lot recently, where a lot of folks want to calculate the Charlson Comorbidity Index or the Elixhauser Comorbidity Index using real world data. It makes perfect sense. You want a measure of the sickness of any given patient, and it's commonly used as a variable in many statistical analyses to control. And so I want to calculate that for all the patients in the data set. But if you're not careful, you can actually really skew your calculation. And so I have 3 patients here. Our patient on the top has been a patient at UNC from 2010 to the present. We have lots of data on her. You can see that she has a couple of chronic conditions, diabetes, hypertension. She's had a major surgical procedure at UNC, and she had a bout with skin cancer. We know a lot about this patient, and I would feel very comfortable calculating a Charlson on this patient, because we know that I'm sure we're missing some data. The EHR is not a holistic representation of all patient data, but we probably know enough to validly produce a Charlson on her. On the other hand, patient that's on the second row here, the only time that he's ever showed up at UNC is for an ED visit after a car accident. Showed up once, got treated, got sent home, and was never seen or heard from again. If I calculate a Charlson on him, I'm going to get a 0, probably. And I don't know if that's because he actually has no Charlson conditions, or if we just don't know anything about him. Without careful cohort definition, I am very likely to underestimate his comorbidity burden just because of missing data. And then there's a third flavor that is a little unique, which is that there are patients that only see one specialist or maybe 2 specialists at a healthcare system. And that specialist is only focused on the thing that is their specialty, and so is only collecting data in that domain. This patient just goes to ophthalmology at UNC. They've never been to UNC for any other reason. You're going to see a lot of really complete ophthalmology data for this patient, but you are not going to know anything about their diabetes. You're not going to know anything about anything that is chronic. And so again, we're going to be at a major risk of undercounting the comorbidity burden for this patient due to missing data. There's also bias. So people who seek healthcare are not representative of the population. I think that's pretty well known. But one thing that I make sure that my students are always real aware of is how much EHR data skews towards sicker patients, and that it is absolutely critical to think just as much about who is not in your data as who is in your data. And I use this retracted paper as an example all of the time, where this was a finding where treatment with ivermectin is associated with decreased mortality in COVID-19 patients. Well, it turns out that what they were doing was comparing patients that took ivermectin for COVID-19 with patients who were treated with remdesivir for COVID-19 in sort of a attempt at a comparative effectiveness analysis. Patients treated with remdesivir are very, very sick, or were very, very sick in the beginning part of the pandemic. These are people who were hospitalized, who may have had a very high comorbidity burden, and none of that was controlled for in this analysis. Patients who were taking ivermectin were generally not hospitalized. They were people who came in as outpatients for COVID-19 and just happened to know that they were taking ivermectin. Ivermectin was not being administered in the hospital. So all of a sudden you are comparing the outcomes of a very, very sick cohort to a cohort that's not very sick at all. And it's completely unsurprising that the very, very sick cohort had higher rates of mortality, regardless of what drug they were being treated with. And so, this is a particularly severe example of this principle, but I think that this happens in a lot more subtle ways too, when you're not remembering that the EHR data is fundamentally going to be skewed towards people who are seeking care for being sick. And then there's the data collection itself. So, the EHR is certainly a tool for clinical care, but we all know that it's also a major tool for billing. And so a lot of the data that's collected and retained in the EHR is for billing reasons. And that data is still valuable, but it needs to be considered in the context of being financial data. This is particularly true in inpatient coding, which is often done by professional medical coders rather than the physician putting in the codes themselves. And a lot of that is to justify, understandably, to insurance companies and to Medicare, the acuity of the visit as well as the complexity of the visit. And that means a lot of stuff doesn't get coded. And that's totally understandable in a financial context because the hospital's not getting reimbursed because you had a high fever. They're not getting reimbursed because you had intractable fatigue. They're getting reimbursed because you were hospitalized with ketoacidosis. And that's going to be the main thing that's coded. And so when people try to do research on things that are more symptomy, cough or fatigue is a big one, particularly in the long COVID space, they're going to find some matches. There are people that have those codes, but the people who have those codes on their record are at just a small slice of people who may have had those symptoms. And those symptoms are simply not coded because there's no reason to code. In addition, for those of you who are clinicians, I assume this will resonate. Clinicians are already asked to record so much data in the EHR when they're doing their job, clicking so many buttons and so many checkboxes that it completely makes sense to me why not trying to enter structured data on every little last thing from the patient, that there just isn't time to do that. And so we have to just accept that the data we get are the data we get and interpret accordingly. So I gave you a bunch of pitfalls and I gave you a bunch of caveats, and I've given a version of this talk several times, and I always realize that at the end of it, it sounds like I'm really negative about EHR data. And I certainly am not negative about EHR data. That is where I have chosen to center my research career. I think EHR data is an incredible resource and needs to be interrogated even more than it is now. I think the point that I want to always try to make, as I hope I have been doing for the past 30 minutes or so, is how important it is to be responsible with it. And so I've now adjusted this talk to make sure that I talk about some really good use cases for EHR data so that it's not all scaring people out of using it and more scaring people into using it with the most rigor and reproducibility in mind possible. So one of those use cases that I want to touch on is target trial emulation. Now, target trial emulation is the process of simulating a randomized control trial in the EHR. And doing that is a very methodologically intense endeavor in that you are actually building a pretend clinical trial in the EHR with a protocol, with inclusion-exclusion criteria, controlling for all kinds of things, and making sure that the patients that you include in your trial are as close to the kinds of patients that would have ended up actually enrolling in an RCT should you actually do one. So this is not something that you can just snap your fingers and do in a day. This takes a lot of really careful analysis and a lot of peer review and going back and forth to make sure that you're doing this as rigorously as possible. So yes, it is way irresponsible to say that doing some EHR analysis is as good as a randomized controlled trial. That is not responsible at all. But this is not a replacement for a randomized controlled trial. I see two really important use cases for TTEs. One is as a precursor to a randomized controlled trial, because RCTs are extremely expensive. There's a lot of overhead to set them up. And I see a lot of interest now in doing TTEs, which are not a trivial amount of work, but are certainly less work than setting up an RCT, to kick the tires on a hypothesis before standing up an RCT. And so now, of course, this doesn't work for drugs that don't exist yet or brand new drugs, but it does work for drugs that, for example, they have a different indication and we're trying them out to see if they have other purposes that they might be useful for. That's a perfect example of a time when you would maybe want to consider doing a target trial emulation to see if there's a there, to see if you see some signal. And if there is signal, then that is even more impetus for actually standing up the real RCT and going to all of the time and expense to execute that. So I think that's a really nice use case. The other use case that I think is great is in the other direction. And that's actually what I have illustrated here on this slide, which is replicating an RCT. And so I'm using the Paxlovid trial here. Maybe you can tell from some of my examples that I've done a lot of COVID work. So I have a lot of COVID-y examples, but the Paxlovid trial that Pfizer did had, I want to say it was 1,000 or so participants, and showed, a significantly decreased risk of hospitalization and death when compared to placebo. And what we chose to do a couple of years after Paxlovid had already been on the market and used was to see what that looked like in an actual population of patients, a much, much, much larger population of patients that had tens of thousands, hundreds of thousands of people, as opposed to 1,000. And so you can see at the bottom here, we actually did do that TTE, and it's nice to be able to say that we were able to replicate the findings of the Pfizer trial. So it worked in the population size or the large size analysis, as well as it did in the RCT. And there's something very validating about that. It is so important to not just settle on a finding, but to also try and reproduce it as much as possible. And this was one of those things that we did to do some reproducibility. Another use case for EHR data that I've been really interested in lately is population surveillance. And you'll see that I have an asterisk after population because I always want to make very, very clear that when I say population, I am not talking about the full population of the state of North Carolina or the United States. I am talking about the population of patients who use UNC Health as their healthcare provider. That's the only population that I have ready access to. If we were talking about a multi-site study, the population we're talking about is the population that uses any of those sites as their healthcare provider. But definitely wanted to be very clear about that definition of population, because surveillance is something that you don't necessarily only want to do within a single health system. You may need to do that at a national level or a state level. The reason that you may want to only do it in a health system, though, or a consortium of health systems, is if you're looking for patients who might be good fits for clinical trials or have other needs to define a cohort within those health systems, you can surveil them using EHR data in a way that would not be possible without that scale of real-world data. The example I have here is a real project that we're working on around cancer registry data. So cancer registry, at least in North Carolina, I can't comment on how it works in Ohio, but I suspect it's probably similar, is that there is a cancer registrar. It's actually a team of registrars that every day of their life, that their job is combing the EHR for record of analytic cancer cases at UNC Health They input that data into a registry, and then every 6 months or so, they send that registry to the state of North Carolina. The state of North Carolina then compiles all of the registrar submissions from all of the cancer centers in the state, and that becomes the state tumor registry. That process from the diagnosis date for a single patient to when the state is ready to release their research registry, or sorry, just their tumor registry, is about 2 years. And so there is this enormous lag time between the diagnosis and 2 years out when the tumor registry actually is able to be reused by researchers. Now, that's not to say that cancer registry data is the only way that you could identify patients with cancer in the EHR, but it is one of the most reliable ways that we can do that. And it's because those human abstractors are putting so much detailed data about cancer cases. They're also differentiating very well between cases of cancer that are actually being treated at UNC versus cases that might be just a second opinion and we never see that person again. So there's a lot of rich data there that is incredibly specialized, and it's 2 years out of date by the time we get it. So what we are trying to do now is, this is actually one of our first attempts at using AI at scale. And I know I haven't talked much about AI in this talk because I haven't been focusing much on free text data. But this is one of those examples where we are attempting to use AI to intercept the data at that step one, when the cancer registrar would be manually abstracting those cases into the registry, so that we can use the data right then and there instead of waiting 2 years for that adjudication. We're looking for AI to sort of help with that adjudication process to get data in researchers' hands faster. That will enable us to answer the question, which patients have cancer at UNC? Which you would think would not be a difficult question to answer, but with only structured EHR data and a 2-year-old cancer registry, it actually is quite a difficult question to answer. And then a final use case that I wanted to make sure to touch on is this trend of really large-scale linked data analysis. And the figure on this slide is specifically from the NIH All of Us program, and I think many of you are aware of that. If you have not heard of All of Us, it is an effort to recruit 1 million Americans to submit their genomic data, to submit their EHR data, and to submit detailed survey data to a repository that is available for research in a very low barrier to entry way. It is very much real world data, and it's a really exciting resource to use. If you have not checked it out before, I really encourage you to do so. But one thing that's particularly cool about All of Us and other consortia like it is that it doesn't stop at EHR data. There is an understanding within All of Us that the EHR data is not a holistic representation of a patient and of a patient health, and that linking as many other sources of real world data as possible with the EHR data will get us, to be able to answer many more research questions than we would be able to with just the EHR data. So in this figure here, you can see that we're talking about a patient over time, and life is long, and there are many, many different touch points during a person's life where they're going to different healthcare systems. They have different insurers. They are living in different locations with different environmental exposures. And all of those factors can be linked together in a linked data resource like All of Us. And as you can see in the bottom of the image, you can kind of stack all those sources on top of each other to not provide a completely holistic picture of a patient, but to fill in some of those context and data gaps to make analysis a lot more robust. So this is another plug for the All of Us program. If it's not a resource that you've tried out, it is extremely cost effective and really a great place to get your feet wet with EHR data science if that's not something that you've engaged in before. Okay, so wanting to leave about 10 minutes for questions, so I'm going to turn to takeaways. I didn't directly talk about this, but I think it's sort of important to end here, which is that a lot of these giant sources of EHR data or EHR and linked data, like All of Us, one of the things that they've focused on deeply, particularly recently, is democratizing the data, wanting to make the data available to as many people as possible with as low a barrier as possible. I think that's beautiful. Science should be open. I personally love sharing every single thing that I do as widely as possible in case somebody else can make use of it. On the other hand, I also think that sometimes this democratization of data means that expertise is not as valued as it could be. So, in the extreme situation, expertise tends to gatekeep in that, if you haven't spent 10 years working on such and such method, then you have no right to use it and no idea what you're talking about, right? We don't want that to be our culture. But I also think that landing somewhere in the middle between these two extremes is probably what we want to do, because if you go too far to the democratization of data, you end up with science that is built on misunderstood data. And what I worry about is with the proliferation of massive numbers of papers coming out of these EHR repositories that are coming from people who are very new to EHR data analysis, or maybe are just kicking the tires on EHR data analysis and really haven't spent much time with it. If they come up with questionable conclusions that are not caught during the peer review process, which does happen, then I worry that it will decrease the overall faith in the value of EHR data for science. And so I don't know who wins this tug of war, but I am hoping that we can arrive at a place where we land somewhere in the middle and actually neither side wins. I think the solution to this is team science. Informatics, health informatics specifically, is team science. If you are practicing health informatics without a team, then I would say there's no way you are being rigorous, and there is no way that you are ensuring that your science is reproducible. And so whenever I do a project with electronic health record data, I make sure to have at least these 3 people on my team, if not more. I would never do an EHR data project without 1 or more clinicians involved, specifically experts in the disease that I'm looking at or the condition that I'm looking at. The clinical informaticist, again, sort of the unsung hero of this arrangement, the person who's doing the data cleaning and that data harmonization that we spent a bunch of time talking about, the person that's going to recognize that one of your sites is making 100 inpatient visits for when it should just be 1, that's the clinical informaticist. They're often not on faculty, they're often a staff scientist or maybe an analyst in your CTSA. They are a critical component of this study to help you contextualize the data and use it appropriately. And then, of course, a data scientist, a biostatistician, somebody who is really going to dive deep in the methods and make sure that you are not, going down the road of making spurious associations and saying things that really are not appropriate conclusions to reach, backed up by the data that you have. So I do think that team science is the key to all of this. And, on the positive side, I have seen, I just got back yesterday from the main informatics conference in our field, the EMEA conference. And the number of times that I heard team science repeated over and over again really gave me a lot of hope in this area. So I think there's a recognition of how important this is. So where does this leave us? I think hopefully I've convinced you that if you're going to lean on that culture of expertise at all, that the place to do that is that first step where you are curating the data, where you are understanding the context behind the data and harmonizing it in a way that if you're analyzing across multiple sites, you've got apples and apples and not apples and bananas. I do want to stress that I don't think data is a playground. And that p-hacking is still bad, whether you're using real world data or any data. And rigor and reproducibility is still our North Star as scientists. To that end, identifying bad use cases for EHR data is as important as finding the good ones, because that will just make people, particularly trainees, even smarter about identifying when it's appropriate to use EHR and real world data and when it might not be. And then, as I just extolled, the best EHR studies are team science driven. So with that, I will close, and I would be more than happy to take any questions.
Oh, I see that maybe Carl has a question. You are muted though, so we can't hear you. Maybe not. He's still muted. Let's see. Okay, well, while we're waiting for him to figure out his mute, we do have two questions that were sent in previously. So the first one is, what are the biggest opportunities that AI can bring into research with EHR data?
So I'm going to answer that question from two perspectives. One is on that data curation and engineering side, and then one is more on the scientific finding side. So on the data engineering side, I mentioned the tedium of data mapping. And I think that the best uses for AI are to do tasks that are extremely repetitive and tedious for humans to do so that we can spend more of our time on the really sticky problems. Let's just use flow sheets as an example, right? So I talked about flow sheets and how hard they are to map. We are looking at approaches, and we've tried out a few actually, and they work decently well. We've trying to allow AI to take the first pass at mapping things like flow sheets to controlled vocabularies. And where the AI really succeeds is when the mapping is pretty obvious. Sometimes the mapping is obvious. And so even having the AI take that first pass of the ones that it's most confident about so that I don't have to look at those, or I could take a cursory glance over those and then spend my energy using my human brain to map the tricky ones is a huge time saver. So I would really recommend exploring more and more uses of AI on the data engineering side, even though, of course, we would not want to, it's a trust but verify thing, right? We want to make sure that we're also reviewing from the human side as well. On the findings side, I have less experience with that. What I will say is on that cancer surveillance study that I was mentioning, we are currently using, we're comparing different LLMs in their ability to extract the same data out of the free text notes that a cancer registrar would extract if they were presented with the same chart. And we are finding pretty okay results. The cancer registrar is still better at it. The human cancer registrar is still better at it than the AI. But again, on the tedium factor, I could absolutely see cancer registrars augmenting their effort with AI to get the easy stuff so that they can concentrate their energy on the hard stuff. And I think my answer would probably be along those lines for any use case, that AI is not bad, but it just should be boxed in a little bit into the things that it's best at.
And we do have another question that was sent in. So this is a little bit of a longer question. So I think this person is on the call. They were saying that they have a PhD in statistics and we're asking for some advice. So they've been granted access to Epic and Cosmos, and they have a basic understanding of those concepts. And with working with MDs, they've realized that there's a knowledge gap between her training and theirs and just need some guidance there. So how would you suggest bridging this gap to initiate her own projects more smoothly without relying on data analysis to get me the data, saying that that's relatively slow? Are there any courses or things like that that you could suggest?
That just means that it wasn't powered.
So I don't know of any course that really covers that extremely critical topic, but I couldn't agree more that that is an issue, and it's one that we deal with in our CTSA all the time. I'm not going to have a magical solution for that, but what I have done in my career is in these team science situations, and that's really what you're talking about, is a situation in team science where there maybe is, we're speaking different languages. And I have found that it is very helpful to actually sit down with clinicians and stare at the data together, because clinicians get a different view of the data when they're using Epic than I do on the back end. And sometimes there's a lack of understanding of, well, I see the data this way in Epic, why can't you see it that way? And when they see how I see the data, I do find that that tends to break down barriers a little bit. But I do think that the question that you're bringing up is a tough one. I will say that in terms of training, if you are not familiar with the OMOP data model, which is not a perfect data model, but it is one of the most widely used data models in the country right now. One thing that's nice about OMOP and the Odyssey Consortium in general is that they have a lot of training materials that are free and available online through the Eden Academy. It's EHDEN. And those videos may give you, in addition to sitting down with the clinician, like I mentioned, those videos might give you sort of a depth of understanding, if you don't currently have one, in EHR data that will ease those conversations a little bit. So I would encourage you to check that out.
And I see that David has his hand up, so you can go ahead.
Yes, yeah, David Kelber, Emily, great presentation. I would just say part of it, that person doesn't have the right people on their team, right? So it doesn't sound like the way the question was posed. You don't have an informaticist, like a physician informaticist as part of the team. And so just to put in a quick plug, we have, a small army, mighty but small, within the CTSC here in Cleveland. So I don't know where that person's located, but really encourage a research informatics consult. And I would say in this model, it would really be to get one of our physician informaticists probably as another member of the team to sort of help with, it sounds like that person has a statistical piece, already reaching out to some MDs, but probably the informatics function that we have here through the CTSC could help with that some as well.
Absolutely.
And I see there's another hand up. Anna, you can go ahead.
Hi, thank you. I just wanted to say my PhD is from UNC, so whenever I see a speaker from UNC, it's always a pleasure. I wanted to ask your thoughts about information about medication and medication adherence in EHR.
Love that question. Meds are one of my favorite topics. And because I see we're coming up on time, if I don't finish, feel free to email me afterwards. But meds are very difficult in the EHR unless you have a feed from SureScripts or a service like that that is going to give you more of an indication as to whether the patient actually picked up the drug. What you get in the EHR, if we're looking at outpatient prescriptions, are prescriptions that went out to the pharmacy. I know that I have been prescribed plenty of drugs in my time that I never went and got, and that meant they never made it into my body. So with that caveat, people still can do drug research in the EHR, and this is the part that I'm not going to have time to get into. There are ways of controlling for that and ways of sort of contextualizing that, but it is absolutely something that needs to be kept in mind because it's a huge gap. Now, using claims data linked with EHR data, much like I was talking about as one of my final use cases, is one way of lessening that gap, because at least the claims data, also not perfect in that area, but will give you a better idea of what was actually picked up. So if I was doing a very drug-focused study, my first inclination would be to make sure that I was using either EHR data with a SureScripts feed back from the pharmacy. That would be great. But if not that, then linked EHR and claims data is a better choice.
Great. Well, thank you so much. This was a wonderful talk. There was one more question in the chat, but for the sake of time, is that okay if I email that to you?
I'm delighted for anyone to email me questions. I love talking about this stuff, and I'm so appreciative for the invitation to talk to you all today.